It's great to welcome you to another episode of Medicine and the Machine with my wonderful co-host, Eric Topol. And today we're just honored to have another Eric, someone I've admired and gotten to know more recently, and that's Eric Goosby. Eric is a longtime native of San Francisco, went to Princeton for his undergraduate education, but otherwise I think remained in San Francisco for medical school, for residency and infectious disease fellowship. He is truly an internationally recognized expert on infectious disease and has really been at the center of the HIV epidemic as it blossomed in San Francisco in the 80s. He was the founding director of the Ryan White Care Act in 1991, which I was a great beneficiary of when I was in Texas. And then as global AIDS coordinator under President Barack Obama, he was responsible for implementing the president's emergency plan for AIDS relief, for PEPFAR. And he also served as the UN Secretary General's Special Envoy on Tuberculosis. He's a member of the National Academy, professor of medicine at UCSF, and most recently appointed to President-elect Biden's advisory group on the COVID-19 pandemic. And we are just extremely pleased to have you here, Eric. Thank you for taking the time to be with us.
Oh, thank you, Abraham. It's my real honor and pleasure to be with both of you today, so thank you.
I thought I'd ask you to begin by reflecting on, the parallels of the HIV pandemic through which we both lived and cut our teeth, so to speak, and your sense of how this has felt, for you on a personal level as an infectious disease specialist.
Yeah, that's it's something that I have often reflected on as COVID broke. Looking at the immediate response at the local level, seeing the delivery system being awoken by individuals presenting themselves to emergency rooms and hospitals was the inciting moment for HIV as well. There were suspicions, but it wasn't really until people reached late stage disease and started to presenting themselves for severe illness with opportunistic infections that we realized that we were dealing with an outbreak epidemic. The difference with COVID is that instead of HIV, which had a 10-year incubation period, people often were without symptoms in that period that sustained. And as a result, had an opportunity to have an individual infected, healthy enough to continue to move around and interact socially and infect others. COVID, the response to HIV took medical delivery systems time to recognize and develop a response. Everything was over years in actual fact, from recognition to developing a test was 4 years later. Developing antiretrovirals were really the earliest were in 1989, but not effective until 94. And those timelines have been accordioned into a 10-month time frame, but the same reactions and delivery system capacity expansions had to occur for COVID that did eventually occur for HIV, but just over a much shorter time frame.
I want to jump right into an issue that I'm sure is close to your heart and that you've, have the expertise to observe and comment on, and that is this pandemic has disproportionately affected people of color, people of low income, people disadvantaged by, healthcare inequities. And now as we roll out the vaccine, paradoxically, there's a great distrust, I suspect, amongst that same group. Can you talk a little bit about the pandemic and the population who has been most at risk?
So minority communities, like with any disease you identify, continue to bear the brunt of late awareness, late diagnosis, late entry into care, late initiation of treatment. And as a result of that, you see outcomes that are less than optimal in these populations over and over again for hypertension, diabetes, coronary artery disease, HIV, and COVID. And I really see this as an example of showing the same disconnect that our delivery systems have for populations that are at high risk because of barriers to accessing and being retained in care over time. They're complicated, they're described well in many places, and we have not developed effective strategies that counters these barriers that continue to demonstrate these disparities in outcome. In addition to that, COVID uh, uh, disproportionately was transmitted in populations that continued to have to face the public. Jobs that were essential, that carried out a needed essential service that are more populated by minority individuals in those jobs, from postal service to transportation services to services in retail. African American, Hispanic communities have higher rates of acquiring those jobs, which tend to be on the lower end of the pay scale. As a result, the ability to kind of create a bubble in Zoom meetings or having meetings as a means to do your work was something that did not fall to everybody, especially essential workers, and added to the disproportionate impact on minority communities. The third reason is that oftentimes minority African American, Hispanic communities have comorbidities from diseases that have not been diagnosed or adequately treated, that positions them to have to be more susceptible to the ravages that COVID presents. So I think all of those were part of it. The final reason, the fifth reason, Abraham, and I know you're intimately aware of this, is the distrust that minority communities have developed over the years because of real and perceived transgressions that have been wrought on the population by bureaucracies and institutions that fall into the public sector. And I think a lot of it is true and based in real facts, and a lot of it is by word of mouth and has been amplified as people try to make their point. So I think we have a complex awareness of COVID, the threat it affords, the responses that have occurred, and the disproportionate impact on minority communities have been interpreted in a variety of ways that may or may not be accurate.
I wonder, Eric, if you could lay out what you would think would be the best way to titrate the hesitancy and mistrust with respect to vaccines, just because if we don't get as many people as possible, as you know better than us, we're not going to get out of this pandemic.
Yeah, well, Eric, I think putting ourselves in acknowledging that this is the topography that we're in, that the mistrust is front and center, that we as a medical delivery system have not embraced and established credibility deeply into minority communities, and have to acknowledge that we've got that to make up. To do that, using, and I use that word lovingly, community-based organizations that already are identified by the community that you're targeting and trusted by that community is the rapid way to do it. And HIV did a lot of that in understanding the different role that high-risk groups have in being identified and retained in delivery systems for diseases that they carry for their lifetime. so chronic progressive diseases. And it's worth taking the time to understand barriers to access and retention strategies because you have a chronic progressive disease. COVID is a little different, but highlights all of those biases and prejudices that delivery systems present and perceptions that patients have in deciding to engage a delivery system. And I think going back to community-based organizations, faith-based organizations that begin from a position of credibility is the way to reintroduce it. Unfortunately, as you've said, Eric, it has to happen yesterday.
Right.
So doing this rapidly and moving forward with the deployment of the vaccine in spite of these barriers is still going to be needed.
Eric, I was pleased to see that you were appointed to the advisory board that's going to help President Biden with this problem. And if you look at the previous ways that the administration has handled this, other than the excellence in the vaccine being trotted out at a speed, frankly, that I didn't think was possible, there have been many, many missteps before and after that, including with the distribution. We've had Vivek Murthy on this show, and we're really honored to have spoken to two of you who are on this advisory panel. Can you broadly share with us what President Biden's strategy and your strategies might be going forward with this?
Well, we are deeply focused on the first 100 days. President Biden elect has been very clear about putting 100 million as a target for that first 100-day period. We have unpacked that and looked at state by state and kind of large city by large city, how that would play out. Our attempts to connect with states and local community processes that are rolling out the vaccination have largely been at the state and local level. Our ability to get an understanding of what the federal orchestration is of that has been spotty. We haven't been given kind of the entire depth and breadth. We've been given kind of vertical visions in areas, which has told us that we need to carry the dialogue to the state and local level, which we have done. I believe that the vaccination effort is first, second, and third on the list. Doing that in a strengthened and excellent way is essential, and keeping the rollout going so people aren't put in periods of long waits and begin to develop narratives of being excluded from accessing the vaccine, which we have already seen, even with minor waits. And in talking to the manufacturers and their ability to keep the supply line robust, they are confident they can do that. So we are now factoring that into how we distribute vaccination. In short, the dialogue has been in modeling whether taking an individual and giving them a shot, waiting 2 or 3 weeks for the second shot should include hoarding of that second shot for that person's second vaccination effort. And what we've modeled is looking at how many we get under the vaccinated curve for the first shot if we just move into vaccinating everybody with available vaccine, knowing that the manufacturers will be able to, on the other end, within a 2 to 3 week period, supply the next dose. We're not decided on how to handle that, but the preliminary modeling looks like we can potentiate the number of people who do indeed get vaccinated, more numbers do, by the tens of thousands in that 100-day time period. We're not making bad decisions to just do it quickly. We're just seeing if we can accommodate that unmet need more rapidly, more comprehensively. And again, it's predicated on the manufacturer's ability to continue the supply. That with a strengthening of testing, specifically on how schools are going to reopen, the frequency of testing, the type of testing, how that relates to quarantine duration, and trying to free up some of those decisions in containment uh, are the other part of the strengthening exercise. All of this is being discussed regionally as well as by state. So we're looking at state level discussions, which have largely occurred with the Trump administration. And we're now trying to lay over that a regional distribution of human resources, which are more often than not the rate limiting fact for expanding services. So California, the Bay Area, understanding their human resource needs, and within that geographic area, moving people around more freely is kind of what we're trying to look at. So those are the areas that we're probing around. And
Right. I mean, I wondered if you could comment on this, that it's going to take a while, even with the most aggressive vaccination implementation, which obviously hasn't started out as well as we'd hoped. And during this time, we now confront this this variant or strain, if you will, the B117, which is more infectious, obviously. And there are so many other things we can do. You alluded to the testing, but as you recall, back in April, the post office wanted to send out 650 million masks, and that was thwarted by the Trump administration. And what about all these things that we could do, like getting higher quality masks, N95s, K95s, or better surgical masks to every household, rapid home test to every household, better genomic surveillance, digital surveillance, wastewater surveillance. I mean, there's so many things we could do. And of course, there's no enforcement of anything, that in these months that while we wait to try to achieve a herd immunity level.
Yeah, Eric, all of those are being looked at and or are looked at now. If they hadn't been, they all have utility and should be part of the toolbox that municipalities, universities in particular, kind of academic medical centers that afford real monitoring of the larger population. Pooling of sampling is the other piece that has been looked at. All of those, to varying degrees, have been tried but not brought to scale anywhere. And I think what we've tried to do is understand what are the best practices, for lack of another word, and some of what you mentioned could be best practices. Very little of it has been shown definitively to play that role, but all work well enough to test it. Very few of them have been tested, so to my surprise. So we are taking that step where appropriate, and I think there will be an expansion of what we think are best practices, and then those will become more widely available with technical assistance associated with it. The ability to bring rapid assessment of a problem to a state or a city and a remedy is very much part of what the Biden-Harris new strengthening exercise will look like.
Stay with us. We'll be right back with Medicine and the Machine.
Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's editor-in-chief, Dr. Eric Topol, and master storyteller and clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
I want to ask you a broader question about race. I think that when Black Lives Matter exploded, sort of a national awakening of consciousness, I was hopeful. I was excited, and it almost seems like it's very quickly slipped away from the dialogue in the way that I'd hoped it would remain front and center. So this is sort of a broader question, one that we've wrestled with several times on this show with different speakers, about race in general, about society and race, and how that colors everything that we wind up doing.
Well, I'm not surprised you bring this up. It's for those of us who've moved through life uh, in a minority relationship with a dominant culture. It's something that is the kind of unspoken, undealt with issue in the United States, but globally. Our, as a species, propensity to identify same and other has played out in ways that continue to reverberate through every society on the planet. And the experiment that has been the United States has taken a forefront in kind of the sociologic evolution of a society in the race sense on many fronts, but has not put a purse string around the dilemma and taken it to completion. And what I mean by that is acknowledge what happened with enslavement, acknowledge the impact that had on individuals, families, and communities that continue to reverberate in all of our large cities and rurally, but we don't connect the dots. And it's not for blame, it's to understand the strengths and weaknesses of the social makeup of minority communities as they deal with dominant cultures, and that minority dominant culture schism. So minority input is included, and part of the solution needs to be concretized, institutionalized. The United States looked like it was going down that road at different points in its history. And I would say the Black Lives Matter episode brought it to a frenzy with the George Floyd activity and the reaction to it in so many municipalities. I too shared your hope, optimism that this was going to be different. But we have seen every time there has been a rise in awareness, it spreads a little bit, but then it recedes. And I'm fearful that we are seeing that pattern once again. And I am hopeful that this administration, the Biden-Harris administration, could seize everything we've just talked about and seize the receding opportunity that engaging in a dialogue around race has. But I would say that COVID has shown those disparities once again, and would be a wonderful opportunity to bring a discussion around race to the table, and to bring an expectation that there be an institutional reaction, response to the fix. That we try to think about how our institutions, I know Stanford has done a lot of this, I'm sure Scripps has as well. The discussions around race that have occurred have been different for me at UCSF than they ever have been before because of the awareness that's happened. But we haven't figured out a way to capitalize on it. So I share your concern.
I think one of the things that strikes me in this pandemic is the science has been so very good, and to watch it evolve in 10 years has been amazing. But it seems to me that we need to bring that kind of scientific approach to race. Instead of warp speed around a vaccine, we need a warp speed around race rather than another Band-Aid. And I don't quite know what shape that takes, but it seems to me that's the kind of effort that's being called for.
I would agree with you. I think, perhaps all of us thinking about how to challenge the administration to engage on this issue, thinking of a call to arms, so to speak, coming from kind of an eclectic but credible group. There's a willingness to do it. So it would be helping the Biden-Harris administration just get the momentum to push it over. Targeting some of the Hill leadership would be my thought on that as well. But I'd love to think with you guys about how we might leverage that, because I think this is an opportunity. All four caucuses in Congress are all seeing this in the same way. They're all talking about it.
Well, I think having Kamala Harris as vice president is a wonderful start, and we're all excited about that. I want to ask both of you about a phenomenon that I find astonishing, which is more and more physicians and nurses, up to 50% in some places, turning down the vaccine. You know, again, pointing out that science alone isn't enough, even amongst people who you would think are being scientific about this. And what are your thoughts on that? That seems like we can't get out of the gate if we can't get our own people to take the vaccine.
Yeah, I wonder if that's
Go ahead,
going
Eric.
I just wonder if the early percentages of healthcare workforce that are reluctant will change over time, because we already have seen with this extraordinary high efficacy, that it was moving in the right direction. But I'm very interested in what Eric thinks as to why there still is a residual significant minority that are unwilling, at least at this point, to go ahead with the vaccines.
Yeah, I have wondered what somebody with a scientific on point ID background even is looking at when they say they're hesitating to engage in the vaccine. My gut is the mass action of people getting vaccinated will win. It will take longer because of that delay. But I think the majority of people will eventually take advantage of the vaccination. Other than unpacking it, other than explaining that phase 1 through 3 for approval were not shortcut, that the numbers were larger than we usually use in vaccine studies. And that the criticism on how long we have followed individuals gets better every day, and that days and weeks are added to how long we see the cell-mediated response lasts, and there's no way to shorten that. So it wasn't a truncated approval process. It was one that went through the same hoops that any vaccine goes through. We just did it in a way that assumed the product was going to work, and we stood up manufacturing when we started the phase 1 study. So whatever the product was going to go right into a phase 3 that they'd already put all the bells and whistles on. And it's changed in NIAID's thinking how they should do clinical trials, because it has startled everyone how effective it is, and the criticism on it is really falls short of being anything worrisome or that. So I think Tony Fauci's working groups have noticed this and are kind of re-looking at everything they're doing with clinical trials in other arenas.
I think.
Yeah.
Oh, I'm sorry, Eric. I was just going to say that the way FDA took on the vaccine review internally and with the external review, the changing and tightening of the EUA. And as you already pointed out, these are a couple of the largest vaccine trials in history, and conducted in expeditious way that is just without any shortcuts, getting to complete efficacy. Now, what we're seeing is, because of the supply issue, all these newfangled recipes, half dose, 1 dose, delay the second dose. Can you comment about that? Because, then why do you do these trials if you're going to come up with these new concoctions that haven't been validated?
That are not based in science. We're making recommendations that we're ignoring the science we've got. No, I agree with you that we should follow the science with what we recommend. If it gets to the point where the supply on a manufacturing level is going to fall short of the demand, which we're not there yet, if that indeed happens, those types of considerations could be, I think, considered in the face of the presence of the surge with the emergence of the mutant. And, the more rapid, the more contagious aspects of it are real. And it does appear anecdotally now to younger people seem to be succumbing to this at higher rates than they did with the original COVID. And I think we're seeing that with the South Africa even more so. They're noticing that kids are coming in and getting admitted to the hospital at 2 to 3 times the rate that they were earlier in the year. So I do think that the education part is important. I guess I'm old enough to kind of think that people will decide they're going to use it or not, and that we can only do so much to prepare that ground. We're obligated to do everything we can. Don't misunderstand me. But I think it will ultimately come to a personal decision, and that is something that I think we just have to watch and be available and ready. But my guess is it's going to pendulum swing into most people getting this vaccine.
You know, your perspective on the world and infectious diseases is really quite unique, from your work with PEPFAR and then your work with tuberculosis as the UN Special Envoy. Let's talk a bit about COVID and the world in terms of, you know, the gains that were made in the PEPFAR era. What is going on now as you sort of put on your global hat in terms of countries that were, you know, in desperate straits without PEPFAR? Where are they now? What's happening with COVID? And what do you see from that perspective?
Well, I think that we have been lucky that COVID has not had the same ability to spread in sub-Saharan Africa, Southeast Asia, shy of the new variant. And that has presented a much calmer move as the outbreak expands in sub-Saharan Africa. South Africa, Nigeria being the worst hit. And I think that the global response coming out of the World Bank to set up a fund, COVAX is what they're calling it, that Gavi is going to administer, that basically put $12 billion down for vaccines for low-income countries. That is being taken seriously. It's being worked through with the African Union CDC and Gavi, and they're partnering with ministries of health to understand what the vaccine burden will be. And it's a real effort. So that looks like it will be very helpful. The second is the Gates Foundation, in particular, looking to play the role in identifying stragglers, those who are slower in standing up a capability. So directed deployment of technical assistance. They are saying they will be a funding line for that. And the US with Center for Disease Control, with DFID in the UK, with Japan, Australia, and with, believe it or not, China, have started serious discussions convened by WHO on what kind of mobilization of human resources can be expected. Not solutions, but more of a start than I've ever seen for any other outbreak. So I'm optimistic that these are the vestiges of what will indeed grow into a redwood tree. So,
I wonder, on that light, could you comment? The continent of Africa has done so admirably in the COVID pandemic. I mean, it's just extraordinary, and it makes the U.S. performance look even more austere. Can you comment about, was the prior experiences that they've had led to this enhanced ability to respond? Countries like Senegal and so many others have been, extraordinary. Or is this, still time to come where we'll see issues, or related to underreporting? What's your sense about what's happened in the continent?
Yeah, I think the initial slowness of spread really reflected the lack of people movement on the continent more than anything else. The spread that did occur were at hubs, Nigeria, South Africa, huge hubs for coming into Africa. And I think once the person is in their home, the average African does not travel much. I mean, within driving distance is unusual. Most people are dependent on walking still. And I think that saved them. I think the ability to spread that virus was severely limited.
Wow.
And did not have kind of high risk groups. It really stayed in general population. So you didn't have, some segments of the population rapidly accelerating in transmission like you did with HIV and like you do with TB. So I think that saved them. I think we are not out of the woods yet. I think over the next 6 months, I believe the awareness that they dodged it initially is there, and that containment, mitigating interventions, non-pharmacologic, are still the tool of choice and will be effective. Emphasizing in country discussions that they have kept their containment low enough that case finding and contact tracing still is the tool that will keep the lid on it. And the US has been the example that we've used in seeing when that runs afoul. When the numbers get too high, as your percent positives go above 8, 10, 15% positives, you move into community spread that you can't stop until you do something really drastic, like UK is doing today. So the epidemiologic awareness in ministries of health, because of PEPFAR and the individuals and the surveillance and reporting that PEPFAR demands, has created a cadre of people who know how to stand up those types of things, which are the core of a pandemic, epidemic outbreak response. We really do have contact tracers and that are active and experienced in most every ministry of health in Africa, definitely made it easy to expand an already existing capability as opposed to create it anew.
As we wind down, Eric, I just want to ask you, you've had such a distinguished career, and we've also had the opportunity to have Mark Smith on this program, another UCSF product. And, we need to have so many more of you. And I want to talk a bit about the pipeline issue, because this is very relevant to trust amongst the African-American community. Without seeing more of their own physicians out there, it is harder to get the kind of trust that we need. Can we talk a bit about the pipeline? How do we, not have the sort of attrition we have along the way? What are some thoughts you have to share, given your, wonderful, distinguished career? And we just need so many more of you.
Right.
Well, you make me blush. It's very kind of you to say that. And coming from you, it really means a lot to me. I think the lack of presence of minority faculty has a bigger impact than people think. Having your better institutions not have faculty that reflect the demographics of the populations they serve become problematic just for this kind of reason. Normally you go, meritocracy should go on performance and talent only. Well, academic medical centers have made their reputation on keeping that pipeline robust. What they haven't viewed is the need to also put on their plate of duties a need to, in their faculty and in how they move their curriculum to their students, the sensitivities around race, bias, affecting decisions for our patients, but also affecting how that delivery system is used and perceived by these communities has got to be part of the consciousness of academic medical centers. So we train so we create the right product with the appropriate sensitivities around all of this, which many good people in our society are indifferent to, insensitive to, don't understand what you're really talking about, and or are busy enough not to give it the time to unpack it. Good people. And I've seen it with my colleagues on the faculty. Good people who don't really see the disincentive that comments that come from them to residents and fellows get interpreted every way, including racially, when they're just thinking about it in a very concrete kind of matter of fact 1, 2, 3, 4, this is what you need to do, and often convey lack of trust, or the typical example is the resident having to present as if it's an attending presentation every time they present a case, because the attending isn't sure that they looked at the potassium. So they want to hear everything. Now, after the fourth time they do that, you trust the person has done that. And I think that threshold for giving that to a resident or a student who's Black or Hispanic can be interpreted very differently. So I've had residents and a couple of fellows distraught over the fact that they're treated differently in work rounds and teaching rounds that they perceive as totally motivated because I've got to prove myself every time I open my mouth, and my white counterpart doesn't. It may or may not be true, but that's how it's perceived. Right. And academic medical centers need to get down in the weeds on that and heal themselves with that. So we pop out students who are aware of those nuances and sensitive to it because of it.
That's a great point. Really important.
Well, Eric, if you don't have another question, I just wanted to say what a privilege it's been to have you on the show, Eric. I can tell you that we were tickled to hear that you and Vivek Murthy and many other distinguished people that we have been in dialogue with are going to be on this new advisory panel. I hope you'll agree to come back and chat with us a couple of months, maybe after your first 100 days.
Anytime.
Well, what a privilege to get together with you, Eric, after we were residents together at UCSF, and I never had the privilege of having you as my resident when I was an intern. So at least we get to talk to you today, and a lot of your wisdom, phenomenal stuff that you were able to impart to us and to our listeners. Thank you so much.
Well, thanks to both of you. It's a pleasure to have this opportunity, and to spend time with both of you on a personal level is important to me too. So thank you.